We have 2 minutes left, Sonia. I'm thinking maybe I start with my favorite inspirational quote because I think we all need a little uplifting on a Tuesday. And then, Sonia, if you want to kick off with the housekeeping, and that way we can start at 9:04. But one of my favorite quotes I want to share with you all is Maya Angelou's quote. I think I have like 6 favorite Maya Angelou quotes, but I think it resonated since I heard it the first time since becoming a nurse. And it was, I've learned that people will forget what you said, they'll forget your name, but they'll never forget about the way you made them feel. And it's really so true when you think about how much power we hold in just being caregivers and part of our patients' treatment teams. And we see our patients at the worst. And I think it's just very important for us to realize how our contact really can go such a long way with these individuals. We don't know what their situations are. We don't know what the support is at home. Sometimes we only see patients once in a hospital setting. But those small moments really can make such an impact. Even just holding a door for somebody or smiling at somebody in passing, like you don't know if anybody's given them any attention, and then that small smile could just give that little spark and encouragement, because we are living in a very chaotic world, and there's just globally, there's a lot of chaos going on. And unfortunately, a lot of that is out of our control. But what we can control is how we act and how we feel and how we present ourselves to the world and to our patients. So hopefully can just take a little bit of ounce and just be kind to the world and to the people you interact with, because it really does go a long way. All right, Sonia, you want to kick it off? Or I guess take it over, I should say. I kicked it off already.
All right, great. Well, good morning, everyone. That was a really great quote and introduction. So we have some housekeeping, just general asking that everyone keeps your cameras on, that you have your webcam. Of course, we know speaking, mute your microphone when you're not speaking, and then of course, respecting private health information. We have our UAB accreditation and EOE statements. We have disclosures from Dr. Prince. And then we have the QR code here for CME information. You can scan the QR code that's there on the screen. You can also click the link that is in the chat box. And real quickly, just some upcoming Sapport Echoes that we have coming up on Thursday, March 20th. Johns Hopkins will be hosting the Sapport Echo with Dr. Carroll. And then on Tuesday, April 17th, again with Johns Hopkins, we'll have the emergencies and at CD with Dr. Morris. So be on the lookout for those, and we will give you information about April 1st soon too.
Do you want me to share the screen for the case, or Sonia, do you have it up?
I have it up.
Okay, perfect. Adela, are you ready to do the case, or do we? Okay, perfect.
Sorry, I was on mute. Good morning, everyone.
Good morning,
Fadela.
Okay. There we go. So this patient is one of our patients. I think we've had her for like a year or so. 39-year-old female, hemoglobin SS disease, who presented to us initially in the clinic, called to come for pain treatment. When she got here, she was as sick as, I've never seen her, because she normally doesn't get frequent crises. And so we knew that she needed to be admitted. So she was a direct admit from the clinic. On the 18th, so on presentation, she had a pain, she was hypoxic. She was really not being able to like stay awake as well, even though she was in pain. So just looked so sick. She was coughing, and we kind of suspected acute chest, which was confirmed when she was admitted, and they did imaging. She hasn't really been admitted in the last 30 days. Prior to this admission, she was doing really good. I think last year, her last admission must have been like maybe around June. I can't remember. And she's been fine after that. And she did really well. She saw Dr. Law for consultation, and she hasn't done her follow-up with her yet. I think she was supposed to be doing a once-a-year follow-up. No primary care. Initially, she had one, and her insurance, was not accepted by that person. I have encouraged her to try and get another primary care, but she needs a lot of help. Unfortunately, she's not great at picking up her phone or returning calls, and so she still does not have a primary care. Pain for her was generalized at 10/10, and in the clinic up to 3 treatments of IV Dilaudid, still was in a lot of pain. She takes oxycodone at home as needed, and I don't even know if she has any because she doesn't really take it. So I don't know if she had any at home at that point. I think she only said that she took Tylenol or Motrin. Another medication I wanted to mention for her, it's also probably down. She was started on Eliquis for a B, and she's not really compliant with that. We've talked about that several times, but she doesn't really take it, or she runs out and she doesn't ask for refill. And just I don't know when was the last time she took it. She has a history of acute chest in the past, which was also last year. DVT, like I said, her only surgery is gallbladder removal. She has no other major illnesses, including depression. She does really good with understanding her disease and being able to manage it at home. And because she doesn't get frequent crises, kind of work out for her. So scroll down some. So she is supposed to be on hydroxyurea, which also she's not compliant. So she doesn't really like taking it, which is most of them. And I don't think she had any left at home by the time she showed up with us. Let me see. No chronic transfusions at this time. She does have antibodies from previous transfusions. And on admission, we worked her up to have some blood on hold before she left the clinic here. And so I think her hemoglobin dropped to like around 6. So she received 2 units from the between 18 and 19. She received 2 units of packed red blood cells. Vital signs as listed. She was tachycardic. However, her blood pressure was okay. She had a fever. She was on oxygen. This was not room air when she arrived to the thing. That was on oxygen. She was started on 2 liters. Because without oxygen, she was in the 80s in the clinic. So we had her on oxygen when we transferred her. So her other lab values, baseline hemoglobin is usually between 8 and 9. But on admission, her white count were high, kind of expected, but also probably telling us that she has some infection going on. Platelet count was normal. Her retic count was 290, and her last electrophoresis, and we did that before she received the transfusion with the S of 87.5%. So this direct Billy 6.8. It started at 5 when she was admitted, and it kind of like, just increased, went up along with some other changes post-transfusion. So when I saw her the day after she received blood transfusion, she was still pretty sick. She is very sleepy. You have to wake her up in between, asking her questions to get your answers. And I noticed that her bilirubin has gone up. And I asked her about her urine, and she said, "Oh, my urine is very dark." So which she says it was not like that before the blood. So that was like, okay, maybe we need to start watching this one earlier than we normally expect to, watch other patients. This is her chest X-ray, confirming she has acute chest syndrome or probably pneumonia. CT scan was not done. It was a chest X-ray, and she complained at some point of abdominal pain, which she said that happens to her when she needs to have a bowel movement. She hasn't had for days. And so after she had the bowel movement that day, she said the abdominal pain went away. However, I saw that they did abdominal ultrasound for her at that time, which was okay. I think this is the last part, right? Just scroll down for me, please. That's okay. There you go. Yeah, so this patient lives in DC with her mom and her kids. So I think I already mentioned this one. And the two questions that we had, and these questions came from the fact that there was difficulty working with this particular physician who admitted the patient as a primary team. And the problem is, I'm not really sure what happened between us and the hematologist who consulted on the patient. There was no note from a hematologist in the chart, and it looks like he just verbally discussed the case with them and they told him what to do. So he decided to follow the hematologist instead of the sickle cell team. Given the symptoms that the patient was having and the color of the urine and the lab value, we needed to do more blood work to kind of rule out any delayed hemolytic transfusion reaction. And this will have been the second person that I saw with that who had that reaction immediately after the transfusion or a day after. And my last patient, hers, it was real. So I'm like, let's just do labs to make sure before we give her another blood. At this point, her hemoglobin fell back down, and the physician wouldn't have it. He wants to transfuse the patient despite all the symptoms. And he's telling me that he has to follow what the hematologist told him and, doesn't want to follow what sickle cell told him. So we're trying to find out that when we get pushed back from primary teams like that, if anyone has any experience and any advice to give as to what's the strategy to use to try to, advocate for these patients and make sure that we are not doing more harm than good. Of course, if the patient has a low hemoglobin and is affecting them, they're having symptoms, we all want to transfuse, but how do we make sure that we are transfusing safely? Because her dark urine soon after transfusion, like I said, I've seen one patient. I don't know anybody else has seen anything like that in their practice. So that's our second question for you guys.
Perfect. So just a quick summary of the case, and then I'll open it up to everybody for clarifying questions and some recommendations. But again, this is a 39-year-old female with hemoglobin SS who is admitted for pain, hypoxia, and acute chest, has history of DVT on Eliquis, also in hydroxyurea, but non-compliant, has red cell antibodies, and during this admission received a transfusion and developed the dark urine shortly after. And now we're trying to see how to best communicate with the attendings and hematologists on service at the hospital when they're not necessarily working well with the sickle cell team. Does anybody want to go off mute or go on camera too, so we can make it a little more personal and have any more clarifying questions or recommendations for this case? I can talk everyone's ear off, but I'm going to open the floor and let's do this all together from that standpoint. Unrelated to your question, though, all of my patients who have a compliance issue with the late refills, et cetera, anytime insurance allows it, I'll do a 90-day supply. So that way it removes any potential delays from that monthly basis. So they're not getting as much missed doses in that time frame.
Sounds good.
Has anybody experienced something similar? Like there's two parts to this case that we're trying to clarify. First is just when it comes to transfusion reactions. So this individual developed the dark tea color urine during the transfusion, said this is new for her. She's never had this before. What is the typical process that you guys do at your institutions when this is suspected? And then the other side is how can we better collaborate with the providers at hospitals who are taking care of our patients. So if anybody has suggestions, so how they navigate one or the other and want to come off mute, that would be lovely.
I had just one clarifying question just about the case, Fadila. I don't know if you know, it sounded like she's on HOMO too, or it sounds like maybe she doesn't use it or maybe doesn't even have it. But do you know so does she have like hypoxia at baseline, or like is that
No.
from her when she had her PE, or like do we know?
So she doesn't have hypoxia. It's only when she was sick that she came in with that. Yeah.
So the HOMO2 was related to like a prior illness, or she doesn't have any other like known
No,
like chronic pulmonary
no,
condition?
no.
So from a provider standpoint, we do a lot of in-services with the community providers and different hospitals and the emergency rooms and whatnot. And I think when it comes to just provider network and relationships, like we have patients who are going to get admitted outside of our facility. And I think keeping that line of communication open is what's the most helpful. That it might be helpful to identify who are the hematologists at that hospital, who do frequently see patients when they're admitted, and try and see, like, can you reach out to them and have just a little meeting with your sickle cell team so you can have easy communication and just talk about what your concerns are. Because a lot of times when patients are admitted, people just focus on the anemia and the pain, and they don't fully understand the concerns that we have, understanding what sickle cell can encompass. But once you explain it, a lot of times they are open. And this applies for any specialty, like even for nephrology, because I felt like we had referred to patients and nephrology was being really laissez-faire with it. And I explained to them, like, when a patient's creatinine is 1.5 or higher, they have like a 3-year prognosis of either death or dialysis. And the nephrologist wasn't even aware of that statistic from a sickle cell standpoint. So I think a lot of times they might be open to having conversations, and you approach it in a way like, you guys don't do it, say you didn't do your job, or we weren't happy with how this admission went, but kind of get curious and see how can we work together. So when our patients get admitted, we can have a nice collaboration from that standpoint. Is it always the same hematology team? Because I think you said this is the second instance, or was it different hematologist each time?
So I'm not even, I don't think it was the same hematologist. But the difficult part with this whole case was I had to get my director involved, and the director tried to like talk to that attending directly and try to get the name of which hematologist he may have spoken with. That took us a good 6 to 8 hours. He will not give up the name, and we just don't know, with no notes in the chart,
Right.
who saw the person. So finally there was a note that the intern put in, and the intern started a note at 6 a.m. that morning and didn't put the note in until 8 p.m. that night. So they had a discussion finally with my director and the hematologist and the that attendee, and the hematology insisted they're gonna give the patient blood. Mind you, this patient has antibodies,
Right.
so we are worried at this point. And the next day, my colleague who came on that day covering, and she already went in and saw some things and put in orders. And so I had to call her and give her a little report of the previous day and told her we are not to put in any orders because the primary care, they don't want us to put in any orders. So she has to go back, and, discontinue all her orders. And that's why she was worried, like, hey, I talked to the patient say her urine is Coca-Cola, her labs are showing. And previous day, I had ordered LDH, haptoglobin, urinalysis. I had to go back in there and cancel it. So the nurse who had the patient was like, hey, why are they canceling these orders? And it looks like that primary team went back in there and put those orders in. So the next day, when my colleague came on, LDH was really high, haptoglobin was low. And, that kind of like, she's like, oh my God, we have to watch this patient very closely. And at this point, they are really pushing to transfuse. So that's why it was a little bit difficult.
No, and it's stressful when you know what could potentially, what this could indicate, and then you have a team who just has no regard or listening to what your concerns are and just trying to manage. The other thing is, a lot of times I like to empower our patients. So if this patient has known antibodies, like, make sure she knows she has antibodies, what this means. So that way, anytime somebody offers a transfusion, like, patients need to know they have the right to refuse, or they have the right to confirm with their primary team. That I would put the ball in her court and let her know what are the signs of transfusion reactions, and make sure that if we're not able to have a consistent person that you can communicate and rely on from that hospital, then at least we have our second line, our backup line of defense, and having the patient be able to advocate for themselves too. That's challenging, but I think involving the director was important, and just making sure that they can evaluate those processes, especially if you're seeing that the late documentation is negatively impacting patient care. That's something that the admins can handle without having to necessarily put that on your plate. From a transfusion reaction, or Ashley, I saw you go off mute.
I don't know if you guys can hear me, but I think just another point too is sort of understanding your hospital leadership too and who your hospital leadership champions are. As being the colleague that came on and took the case from Fidela, that was sort of, you know, right, we had all this pushback with the, like, our director of the sickle cell program, right, helped push, but like we were just kept meeting, all of us kept meeting guardrails. So we have champions, or Fidela has champions that are there in leadership that also help to push this through too and help have conversations and involve the CMO. So sometimes I feel like as an APP, it can be really intimidating when you have an attending that's like saying, oh, you can't do this, you can't do that. But like, I also think making those relationships, working with your director, working with other leadership people that like have your back too, can help push this forward as well.
I agree.
Thank you.
Ashley, do you want to chime in with regards to the transfusion reaction? Just since you were on the case and can provide clarity, like when we're thinking of an acute or a delayed, or did we just think she had an episode of hemolysis and she was dehydrated and it just made her tea look dark, or her urine look darker? Is it worth ruling out? Like, I have one patient, and Dr. Harrington still made fun of me. Like, one of my favorite diagnoses is PNH, paroxysmal nocturnal hemoglobinuria, and it's such a rare condition, but when you catch it, it's like the most satisfying thing. And I actually have a patient with sickle cell with PNH, which, like, when it was first checked, they're like, why are you checking this? This patient is sickle cell. They have a hemolytic condition. They have an explanation for their DVTs and whatnot. But he also had iron deficiency, which I couldn't find the explanation. And that's what led to his diagnosis, that I would just, if it were to become recurrent and it's not as obvious from a blood transfusion and a hydration status, just rule out potentially other contributing factors.
No, I think it's a really great point because, you know, it's a little early for delayed hemolytic transfusion reaction, right? An acute transfusion reaction, it would fit in that category, but we talked to blood bank and she had gotten phenotypically matched units, and she actually ended up, after that unit of blood, ended up improving. So I think it probably was hemolysis, like her own hemolysis, that was driving it. But I think to Fidela's point, right, like making sure you're working up all those causes and being really thoughtful about patients, especially ones that are alloimmunized. So I think, you know, and having that collaboration with all the teams too.
This was an interesting case. Thank you so much for sharing it. I agree. I think you should identify the leadership within the hospital and just identify what you've noticed thus far, so we can try to do a process and improvement for that. Just make sure that your patients are receiving what they need and there's not pushback and there's clear communication. Because I think the delayed entry of notes, like, that's something that's really difficult as well, because we really do base our recommendations, et cetera, from what the teams are doing who have seen them. So I would keep advocating, and I love how thorough you are in the advocacy that you're doing. So we're always going to get pushback from some providers. I'm not going to stereotype. I was holding myself back. But there's always going to be some providers who are going to push back. And it just, if it feels right in your soul, then you know that you need to advocate and this isn't right.
Yeah.
Just stick to your guns and don't let people make you back down or dim your light.
Thank you, guys.
Awesome. So next, thank you again for sharing that case. I really appreciate it. So next
you.
up, I have Elizabeth Prince, Dr. Prince. She is an assistant professor in the Department of Psychiatry at Johns Hopkins University School of Medicine in Baltimore, Maryland. Go Ravens. She is the director of psychiatric services for the Young Adult Clinic, and following medical school at the Toro College of Osteopathic Medicine in New York City, Dr. Prince completed her internship and residency in psychiatry at Johns Hopkins. She went on to a fellowship in consultation liaison psychiatry at University of Maryland Medical Center before returning to join the faculty at Hopkins. So Dr. Prince, I will allow you to share your screen, and we were going to have a very important presentation today that I think will help all of us improve our skills when it comes to patient interactions and assessment and just being able to capture the most impactful information.
Great, thanks so much for the introduction. And is that the correct view? Can you guys see my slides?
Looks good.
Excellent, and thanks so much for that great case, Fidela. I had talked to Ashley over the weekend when all that was going down, and I was also sharing in everyone's collective anxiety about this patient. So I'm glad to hear that they are doing better.
Thank you.
And I wonder, so she lives in sorry, this isn't a quick aside, but so she lives in DC, so I'm assuming she isn't someone that Miss Kathy could be meeting with?
No, she lives in she's out of the area, so that's not affecting her. But I'm gonna follow up with her because initially she wanted to I just want to make sure she has a primary care, but it's
Yeah.
her insurance because she's in DC. She's got, DC Medicare,
Yeah.
Medicaid. So that's impacting her. And I told her to
Mm.
try and find somebody there, but, she's just not doing it. But given this situation that just happened, I will follow up with her to make sure that she's the last one.
Yeah, and I definitely think that this case is that we didn't talk necessarily about the adherence piece of this case, but I think we can, as we're learning about and talking about motivational interviewing today, I think we can keep this case in mind as well, not only about motivating the patient to be more engaged with care, but also motivating our colleagues to be more engaged with our recommendations. So I'm going to be talking about motivational interviewing today and specifically applications for our patients with sickle cell disease. I don't have any disclosures. Our objectives will be to describe motivational interviewing, discuss behaviors and behavior change in sickle cell disease specifically, and then apply motivational interviewing to a case. So motivational interviewing is a therapeutic approach that was developed by two clinical psychologists. And the fundamental idea is that the more that somebody talks about behavior change, the more likely they are to change their behavior. And the ways in which this can be accomplished are by exploring and resolving ambivalence, and then also strengthening motivation and commitment to making changes. So ambivalence is this idea that somebody has two contradictory ideas at the same time. So you have a devil on one shoulder and an angel on the other, or you both want to eat that piece of cake, but also know that you're trying to cut out sweets from your diet. So you have these two opposing ideas at the same time. And there's plenty of evidence in the literature about motivational interviewing in general, not as much specifically applied to sickle cell disease, but in one of the areas that it's especially been looked at is in like adherence to medications and people with chronic illness and on chronic medications, and it's been found to improve adherence. And then in the sickle cell world, certainly like in our ASH education programs and in some research that's ongoing, motivational interviewing techniques have been used to kind of think about decisions and behavior change in sickle cell disease. So some examples of behaviors in sickle cell disease. So motivational interviewing is about behavior change. So what are the behaviors? Behaviors are at their very fundamental, the things that people do or don't do. And so some examples, this is not an exhaustive list, would be things like taking medications, whether that's taking disease-modifying therapy on a regular basis, or how people are taking opioid pain medications. It can also be related to how people are engaging in care, whether that's presenting to acute care frequently or engaging with routine outpatient visits. And then also just general health behaviors that apply to everyone, things like choices about diet and exercise, smoking cessation, or other kinds of substance use too. These are all things that people do or don't do that are sort of potentials for thinking about motivational interviewing. So this is a framework for thinking about how people change behaviors. So this is from a social psychologist who did a lot of work around what he called the theory of planned behavior. So how do we as humans do or not do things? And there's obviously several different contributors in how behaviors take place. There's sort of on the far left, these attitudes, subjective norms, and perceived behavioral control. So these are all thoughts that people are having. The attitudes are, all of the positive and the negative, all the ambivalent thoughts about doing something summed together. The subjective norm is just the sense of like, is this something that everybody around me is doing or is normal or expected? And then the perceived behavioral control is the person believing, do I even have any control over this right now, or is this just completely out of my hands? And it's perceived behavioral control because people can think they have control or don't have control over things that in reality they do. And then in the middle, we have the intention. Does this person intend to engage in the behavior? And then ultimately the actually doing the thing, the behavior itself. And motivational interviewing really kind of by talking with patients about their thoughts, by building up people's intention and motivation to act on those thoughts, and then making plans on how to enact a behavior that they intend to do, really works at all of these different phases. So the framework of motivational interviewing is to first engage the person in talking about what are their hopes, what are their fears, focus in on very specific habits or patterns that they want to do differently, not just I want the world to be peaceful, but perhaps focusing on something they can do to move towards world peace. And then evoking a motivation within themselves to make that change, and then breaking it down into very practical steps of things they can do to implement that change. One of the biggest tools in motivational interviewing is doing reflective listening. And so just to sort of go through some details of that, listening in and of itself, in motivational interviewing, you want to be doing a lot of open-ended questions, not a lot of yes, nos. And really the idea is getting a picture of the patient's attitudes, the norms, their thoughts about this behavior, and their understanding of their control over it. And then you want to offer affirmation of the things that they're sharing. And this is a great opportunity to build rapport by sort of affirming people's experiences, their feelings, and their beliefs about things. And it gives you an opportunity to reinforce when they're saying things that are thoughtful, when they're wanting to engage, when they're actually talking about change. It also gives you the opportunity to ignore or maybe not and reinforce some of the thoughts or things that they say that don't seem to be kind of moving in the direction that you're recommending. Then the reflecting portion of reflective listening is really about showing understanding and empathy of the person's experience, and is also that space in which you can kind of resolve ambivalence by reflecting back what are the negative sort of aspects of what their current, the current circumstance, and then what are the positives of potentially making that change. And then finally, reflective listening, you want to be able to sort of confirm, understand, maybe summarize what you've heard, these sort of potentially two opposing ambivalent feelings that they're having. So let's just work through a case now. But certainly this is just one example of how we might think about or apply. So this is a case of someone who is perhaps maybe not taking their hydroxyurea, or someone who's not engaging in the care that you're recommending. And so you see them in clinic, they show up, and they're telling you, man, my sickle cell disease, it's so disruptive, it's unpredictable, like unhappiness with the status quo. And that's this opportunity to build trust and express empathy. It must be really distressing to feel like you just have no control over the situation, and to really listen and hear more about their experience. Ultimately, the next step is going to be kind of focusing on specific behaviors or habits. So, what are aspects of your sickle cell disease you do feel like you have control over? Are there things that you do or don't do to try and, have more control? You want to avoid direct confrontation. Why aren't you taking your hydroxyurea is like not going to be helpful. And then you want to explore this excuse me, this discrepancy between what is their goal to, maybe their stated goal is to be drinking more water or taking their hydroxyurea more regularly, and the discrepancy between what they're currently doing or what's currently happening. Then you want to evoke their motivation to make this change. And there are lots of ways to do that. One way that I find is pretty helpful is just kind of adjusting to their level of resistance where they're at, rather than just sort of saying like, you got this, buddy. Instead, you know, how important is it to you to take these medications? You know, like on a scale of 1 to 10, you can even offer and say where 1 is, it's really not that important, and 10 is like, it's the most important thing to me. And then when they give you a number like a 5 or a 7, you can then say, oh, geez, well, it sounds like a 7. That sounds like it's pretty important, but why not a 9? Like what would make it a 9, or why isn't it a 1? Like what makes it as important as it is? So the numbers are really just a way to kind of open up more discussion about like what is their sense of how important this is. You can do something similar with how confident they are. What is their sense of how much they could control this? And you want to reflect as they're talking with you, telling you about what they value, about who they are, and what they want for change. You can reflect that back. Like, geez, you know, I can tell, you know, you always come to your appointments. You're being really open today and discussing what you're looking for. Like, I can tell this is really important to you. Like, let's make this a priority together. What can we do? And then that brings us to the plan phase, which is really about establishing practical, achievable steps for implementing the change. I don't know if anyone's familiar with the SMART goals framework, but that can be very helpful. The idea is to break it down to like one very specific thing rather than I want to take all my medicines more consistently. That's like a really, I mean, depending on how many medicines they're on, that's oftentimes a really big goal, but maybe breaking it down to one particular medicine or one particular time of day. And you want to support their self-efficacy and optimism. You don't want to be saying, oh, well, this is how you should remember to take your medicines. You want to come with what would be helpful for you to remember to take your medicines? What's worked for you in the past? What have you tried that didn't work? What would you like to try next? Rather than saying, here's a pill box, good luck out there. You know, you don't want to just be giving direct advice. At the same time, when people have unrealistic like ideas of things they're going to do that just don't seem realistic, it's okay to maybe challenge that a little bit, or get them to keep thinking about other things that might help. Just a few tips. The real goal is for the clinician to be talking like less than half of the time. And you want to really be getting the patient to be doing most of the talking. You also, you know, your questions should be open-ended, and you want to be offering more reflections than questions. Set your own expectations that this is not something where you're going to sit down for 15 minutes and like therapize the person and, you know, have everything change. This is something that happens over a long time of building a relationship with the person over multiple visits, and pleasant persistence can really work. You know, being that person that people trust. And I think this goes back to our introductory quote today. It's really about how you make people feel. Will help build that alliance and then give you more opportunities to kind of engage with them about changing their behavior and making healthy choices. And then some people are just not ready to change, and ambivalence is where the change happens. And if somebody is not ambivalent, then like motivational interviewing is not going to help. So if they come to you and say, I am absolutely not taking hydroxyurea, I don't believe that it works, you know, motivational interviewing is like maybe not the place to start with that person, because there's not any opposing idea for you to encourage. Motivation is not the only barrier to behavioral change. Things like, you know, people not having insurance or not being able to afford to pick up their medication could also be a barrier to, for example, taking medicines regularly. We've talked about building that trusting relationship, and that some people are just not ready to change. And then I'm a psychiatrist, so I have to talk a little bit about neuropsychiatric disorders. Motivation is a thing that our brain does, right? And so when there are problems with your brain, there can be problems with motivation. Very specifically, psychiatric illnesses like major depression or anxiety can interfere with people's ability to be motivated to do things. Personality disorders and substance use disorders can also sort of alter the motivational sort of framework and circuitry. And then having a brain injury, so a stroke or a TBI, or just some kind of cognitive impairment can also alter how people are motivated. So keeping in mind that many of our patients with sickle cell disease may have depression, may have had strokes, that can mean that motivation can be more challenging for them as well. I have some references here, and that was all I had to say today. So thank you.
Thank you so much for that. I really loved the pleasant persistence wins. I'm like toxic positivity. So it was a fun alliteration. And I think the time that you spent talking about the reflective listening, it's really important because again, it offers us an opportunity to point out positive qualities of our patients. Because I find a lot of times when we reflect back, sometimes we can reflect back positive traits that a lot of times we minimize. Like even in ourselves, we focus so much on the negatives or when things don't go right, but we don't give the same attention when things are positive or what those qualities are. So I think it's important when you are doing the reflection back to them, try to point out some positive things because a lot of times we just get so caught up in that negative hamster wheel and it's hard to get off that. Sometimes that's a small thing that we can do that can actually make a big difference for them. Dr. Prince, I kind of wanted to ask, what is your approach? Because understanding how anxiety, especially depression, can interfere with motivation, like obviously we can validate their experience if they have the awareness that they do have anxiety or depressive symptoms. But when you have somebody that you're trying to motivate, whether it's compliance or behavior change, how do you think the best strategy is for those with the concomitant psychiatric disorders?
Yeah, you know, I mean, I think at the end of the day, you want to treat the depression and that will help. So I think, you know, recognizing that, and it may be in the process of having these kind of discussions about what their goals are and what they think is possible, that it becomes evident that they're depressed because they say, well, everything's kind of pointless. Like, I'm just going to feel terrible no matter what I do. You know, that's the depression talking. So once you found the depression, ideally treating the depression, getting them started on SSRI or getting them connected to therapy or a little bit of all of the above is the long-term goal. In the short term, you know, I think a lot of psychoeducation is really the first step in treatment for any kind of mental illness. So saying, geez, you know, I'm concerned you're depressed. And, you know, this isn't a talk about depression and but you know, hopefully maybe we can do that another time, but depression is incredibly common in sickle cell disease. And so I find pointing that out to patients is that, you know, we don't fully understand why, but we know that people with sickle cell disease are at an increased risk of depression. We also know that depression makes people feel like everything's kind of hopeless and negative. And it sounds like you kind of feel like everything is hopeless and negative. The good news is we can treat this. There's treatments for depression. We can, you know, let me substitute some of my hope for you. We're going to get your depression better. You can feel more motivated to do things, feel more like your usual self. And just know when you're hearing that negative talk in your head that's saying everything's kind of pointless and it's not worth doing, that's not you talking, that's the depression talking and getting in the way of you being your normal self. And sometimes just kind of communicating that message can be helpful for them to understand that their motivation is being hijacked by this other thing that's going on that is treatable, but takes some time to treat. So you want to make sure they're kind of in the loop while you're waiting for all the depression treatments to work.
Thank you. I love that answer. And honestly, that negative self-talk in the head, like when I started there, I had twin newborns in a lockdown. So I had 3 under 2 lockdown. And I think the pandemic stressed mental health and emphasized the importance of that. And therapy was a godsend for me. And I never knew in 30 plus years of my life that I even had this inner narrative. And it's like once I had the awareness brought to my attention and realized like how negative it was, the awareness is that first step. So then you can kind of intervene and change that. But I think, again, just bringing the awareness and normalizing the conversations and how common depression is and how common the negativity and that thoughts aren't facts. And you have the ability to kind of break that cycle is very powerful, and just keep at it, because I'm sure we all have those patients that we pointed out multiple times, but they're still a little bit in denial, which obviously they're not going to change behaviors when they're feeling that way. But if you still see something, just kindly persist. What was it? A patient persistence wins. So perfect. Ashley, I saw you go off mute. Do you want to say something?
No, I was just going to add upon what you were saying, Maya, and maybe add a question that is maybe more patient specific. But we know that the prevalence of mood disorders in people with sickle cell disease, it happens, right? I think, what is it, 30% or 20%? And so I wonder if utilizing that as like a normalizing mechanism for our patients, like there's such a stigma with mental health and getting mental health treatment and being able to really just express those feelings. So maybe it's on the patient specific level, but how do you feel about utilizing that and kind of normalizing it as a part of the process when you're talking to patients?
Are you talking to me or Dr. Fenn?
Well, either anybody.
No, I'm totally kidding. I'm kidding. I'm the psychiatrist. This is your go-to.
So, I think that, one thing that in terms of this idea of normalizing, evaluating people for depression most commonly is, I think doing regular screenings with like a PHQ, for example, like on an annual basis, just like, we would recommend doing cognitive screening on an annual basis and getting an eye exam on an annual basis. I think in that way, we normalize that these are things that we care about as your sickle cell clinician. And so we're going to keep an eye on them on a regular basis. I think that's one way we can demonstrate to all of our patients that their mental health is important, and that it's related. It's not like this totally, like, oh, you have your sickle cell disease and then your mental health is all the way over here. Like, clearly they're related. I mostly work with young adults these days, and I will say that our young adults, I think, are ahead of us older people in terms of being open to talking about their mental health and thinking about how it affects other aspects of their life. But I think, this part of genuinely demonstrating that you care about your patient, having open-ended questions, reflecting, and being that consistent, pleasant, and persistent presence in their life is one way to also get people to open up. And that's certainly something I've learned a lot from Ashley about how to do that. But like just being that person that people really know that you care about them, and then they're going to be more likely to talk about their mental health with you. Whereas if you're meeting someone for the first time and they don't know who you are or why you're talking to them or what you want from them, like they're probably not going to bring up that, like, oh, by the way, I'm horrifically depressed also.
That's a good point. Yeah, definitely inpatient setting, the first time you meet them is not going to be as productive getting those insights than ones we've developed a rapport with over the years. Fadela?
Yes, I just wanted to come in because for some reason, thank you, Ashley, for bringing me to this presentation today, because this just happened to me yesterday with one of our patients, and I feel like, Dr. Prince did this because of that patient, and you didn't even know anything about her. So this young lady, she is pretty new to us, and she's been coming in here frequently. She's somebody who's very out there. She has a job. She has a 2-year-old son, and she comes in, and every time she comes in, she feels like people are looking at her in a way because she keeps coming in here for pain treatment. And we've tried to adjust her pain medication and everything. So yesterday, when she came in, it was not busy yesterday. And that's another side of our, daily job, when you want to run from one patient to another. So it wasn't busy yesterday. I walked into her room, I looked in her face, and she looked more sad than she usually is. And so I asked her, I said, hey, what is really going on? Is there anything that we can really do? Do you want us to look at your medicines again? Because I feel like there's something we can do to help you, but, I don't really know what it is. And she broke down. And then she said, I used to take antidepressant. They used to help me. I think I need to go back on it because I'm really depressed. And she started to tell me how her daily life, her son's father, being out of the picture now, refused to participate in anything. She needs to take care of her 2-year-old son. She's running around after the child. and she stood on her feet on Sunday all day to cook because she want to cook for the rest of the week since she will be at work. And she woke up this morning in excruciating pain. She said, I just want to remember those days when I used to wake up without any pain. And the conversation went from there. And by the time, I spent an hour in her room. By the time we finished talking, she, was like, okay, I didn't know all this feeling somebody else had it. I thought it was just me that felt like that, and I kind of told her it's not just you. There's a lot of patients, including ourselves as providers. We all have these things going on, but it helps to talk about it. She was so happy that she was able to talk about it. And I offer her to see a psychiatrist, but she says she wants to see her primary care. She really trusts him. She wants to see him and get the medicine because he gave it to her before. But if she feel like, at the point where she needs to see a psychiatrist, she will let me know.
That's
Yeah,
wonderful.
Yeah.
that's so great, Fidela. I mean, like really an example of how like when you develop that trusting relationship with someone, they're able to be more open about what's going on. And also that when you help someone treat their depression, it sounds like even years later, they're gonna say, well, I want to go back to them because they helped me last time.
No, yes, yes. Mhm.
Beautiful. And really, that's so nice. It's lovely when we have the opportunity to kind of take that time, because that
Yeah.
extra time that you spent with her is going to have that ripple effect and empower her and realize, because
Yeah.
it's real when if you don't have the awareness, like sometimes you're just like stuck in this really dark cloud that it's hard to see any type of
Yep.
positive light, and you're helping peel back those layers.
And if she comes back in a few weeks and she hasn't seen her PCP yet and she still wants to go on a med, and you feel like you want any guidance on how to prescribe that, you know how to get a hold of me. Just say, oh,
Okay.
well, let's just get it started while you wait for the appointment with your
Yes.
PCP.
Sounds good. Thank you.
Anybody else have any questions or comments or feedback? We got 5 minutes left. Wonderful. Well, thank you, Fadila, so much for sharing your case. Dr. Prince, thank you so much for just reminding us how important motivational interviewing and reflective listening and just taking the time to reflect back and develop that relationship with our patients. Because at the end of the day, a patient and a provider, it's a relationship. We're longer the days are that patriarchal type of way where we're just telling patients what to do and really are utilizing shared decision making and speaking with our patients. And the more you practice, the easier it gets. And just motivational interviewing, it takes time and years to really be able to master it. So just little by little, start asking questions, clarify, reflect back, and keep advocating for your patients. So thank you all so much. Happy Tuesday. I think Sonia will put the CEO code, QR link, etc. Otherwise, it'll be emailed to you later. And I hope everybody has a great rest of your week. We'll see you back next month. And even though we don't have the topic, we have a couple options lined up and they're all very good ones. So stay tuned for that and have a great day.